to to express ourselves, especially children after third or fourth grade, they use it much more common. And then we see that children, they struggle more after third or fourth grade because while other children using nonverbal cues, so they struggle to understand their friends. And then the third item in social communication and interaction is they struggle to maintain their friendship. Even though they want to be friends, they cannot keep in touch, and then they don't text or call, they don't meet outside, and then they usually lose the connection and they end up being lonely. So it doesn't mean that autistic children or individual, they don't want to be friends or they don't want to be with other people. They do, but they don't know how to keep in touch. They don't know how to make friends. But this criteria is not enough to diagnose someone with autism. If someone only has these three criteria, it's called social communication disorder. But on top of social communication difficulty, if someone also is showing some other behavior, these are called restrictive, repetitive patterns of behavior, and then so they are diagnosed with autism. So while they have to have all three items in the first bucket, in the second bucket, they only need two. So this can be stereotype repetitive behavior. This can be like rocking behavior as a child or adult, or flapping hands, or spinning around them, or doing some hand or body behavior over and over. Usually we see these symptoms early childhood. So if someone know any autistic individual for a long time, you will notice that as they grow up, they might have less of this behavior. So another very obvious symptom is sameness, insistence on sameness and strict routines. It can be, you will hear a lot from families and teachers. They will say it's very hard to transition from one activity to another or from one class to another class. And sometimes they want to keep doing the same activity. It's hard to change. And then they like the routine. And when you are changing the routine, they get upset and then they may have tantrums and then they want to stick to the routines. So on the third item here, so sometimes they have very like different strengths. They might have very good memory. They can memorize everything. They can understand the numbers, and then they can do out like complex calculation in their mind or visual memory, and or they can focus on specific topics, maybe history or architecture or collecting rocks and other things. They might have very restricted interest. Sometimes they're very interested in trains. They collect trains and then so they know everything about the trains or other interest area. So the last item in the second bucket is sensory sensitivities. This can look like they process sensory different than other people, so they can have higher threshold or lower threshold to noise or sen smell or light or touching, and then they can be very sensitive to loud noise. They cover their ears or they use headphones most of the time, or they can be sensitive to certain texture like clothing, e.g., like wool clothes, or they may like hugging more than others, or they may not like it. Or they can be, one of the important thing, they can be sensitive to certain food. So you will notice that they eat the same food if it's like more firm texture, they may not eat if it's like a mushy or chewy food. So it's more about the sensitivity. And then, so these symptoms get better as they grow up. And then most of the time when I see like a grown up, so they don't have the second category. And then, so it's very important to teach exposure, like the food texture. So as they are growing up, they can eat variety of food so they can develop appropriately. So there are different type of diagnostic process. The gold standard diagnostic process for autism is there are two different um, process we use. These are ADAS and ADAR. And then these are both semi-structured or structured and used by psychologists. And then they do interact with the child and parents. They observe in certain circumstances, and then they observe and then record their behavior, interaction with the family. These are considered gold standard, mostly used for research purposes, but at the clinic, we mostly use DSM criteria based on our interaction and behavior. So after the diagnosis of autism, so it's actually the first step to understand someone. And then, so the biggest So half of the diagnosis, there are other factors like we need to pay attention. And I'm going to talk about other factors, but first, so these are the factors associated with autism. And then when we look into literature, what might be causing the autism? So there is no certain etiology or there's no certain factors, but studies show that there are a few things. These are associated with autism. It's usually if father's age is higher, and then that might be associated with autism. And then certain drugs and medication, when they are exposed during pregnancy. So valproate, we usually use in psychiatric field and also use for seizure. That's recently showed that can cause not cause, but is related to the autism. And also air pollution, living in crowded places like downtown area can be a risk factor. And prematurity is another significant risk factor. Children who are born very early are usually like more likely to develop autism than other children born on time. So, as a psychiatrist, after we diagnose autism, we need to check uh, another function in autism. It's called the severity of autism. So we categorize autism into three levels, so from 1 to 3. So this is important to understand so their severity and how much support they need as they are growing up. But the level and severity of autism has nothing to do with the IQ level or intelligence. It's like how much support they need when they are grown up, when they are adult, how much support they need to be independent. For instance, level 1 means they are mostly doing okay by themselves, but they may need reminder to leave the home early, to go to work, or sometimes they may need a little bit support with taking the right train or bus to get to the work. So usually they do okay, but they just need a little bit prompt and support to live independently. And level 3 is someone who needs constant support with activity of daily living, like they need support with eating, showering, taking care of themselves, and then so they cannot live without other support. And then level two is in between. And then most of the time, autism spectrum disorder, like they need support from Department of Developmental Services, and then they decide based on severity if they need a support and then how much support they need. This is a graphic I wanted to show you. So this is from CDC, from government website. It shows from 2000 to 2022, like every 3 to 3 years. So they repeat the assessment and they measure the prevalence of autism in the United States. If you look at the 2000, it seems like about 9 children in every 1,000 children were diagnosed with autism, and it's gradually going up. And then, especially after 2010, and then later it's going up. And then, most recently in 2022, 1 in 31 children are diagnosed with autism in the United States. There were a lot of discussion recently about what's going on, why there are more children with autism lately compared to 2000. So there are two different idea about the underlying reason. The biggest reason is we are getting better at diagnosing autism in individuals, and then we learning more and recognizing it better. So more and more people getting access to resources, and then the diagnosis number is going up. But it doesn't necessarily mean that more people have autism than in the past. It means that we recognize them better, so we know the real number. So the other idea is also recommending that so those factors like I mentioned earlier, air pollution, the drugs, and also preterm early delivery might be causing the increased number of autism. But as a autism specialist, more thinking of the number is not really increasing. It's just like we are diagnosing better. And this is another graphic I wanted to show you from the CDC website. These are prevalence estimates based on race and ethnicity. As you see here, they are very close to each other, sometimes a little bit lower and higher, which also tells me so autism is about the same across the different like ethnicity. After diagnosing an individual with autism, and then we have a lot more responsibility to understand what's going on and to help them. Autism is a syndrome, which means it affects a lot of system in our body. It affects our brain, our GI system, our stomach, and then it affects our sleep, and then it affects a lot of part of our body. So autistic individuals, 1/3 of them present with seizure as a child, and then so they need help from neurologists. So it's important to pay attention. Once someone diagnosed with autism, we need to look for other like comorbidity to make sure everything is going fine. So most of the children and adults with autism, they also have constipation or reflux or similar problems. So a GI doctor is usually a part of the team who are treating autistic individuals. And maybe you know someone with autism, and then they usually experience sleeping difficulty. Either they struggle to fall asleep or stay asleep, and sometimes they only sleep like 2, 3 hours. And then this can be challenging for the person and also for the family. In addition to medical comorbidities, so autistic individuals are also more likely to have other psychiatric illness compared to general population. This is also a study, a huge comprehensive study shows that depression is 2.6 times higher in autistic individuals. Anxiety is 3 times higher, and then bipolar disorder 5 times, and schizophrenia is 14 times higher than general population. So these numbers can vary, like they can be higher or lower at different studies, but most important uh, like lesson here is so all psychiatric conditions are higher in autism compared to other neurotypical individuals. So which means when someone is diagnosed with autism, so we have a lot of things to look for to understand if they have anxiety, depression, or also having other sleeping difficulty or other medical conditions. When it comes to treatment for autism, so the main treatment is behavioral therapy. So this is called applied behavioral analysis for younger children. So this is very effective, considered gold standard treatment. But as they grow up, and then if they are also high functioning, so they may usually find it not very helpful, ABA. So they also benefit from other kind of like individual therapy, CBT, and social skills. And young children who have like delayed speech, so they need speech therapists, occupational therapy. Sometimes they have some muscle weakness. They can also use PT, physical therapy. And here it's important to work all together, families, doctors, and other treatment team members. And then we all learn from each other to understand the individual, the patient the best. Sometimes it's very helpful to hear from families, like what it looks like, what triggers the behavior, and then so we can develop a custom plan and treatment. So the medication is also part of the treatment, and then we usually use medication to treat other psychiatric conditions. In here, I will mention the medication. So first of all, there is currently no medication that treats the core symptoms of autism. So there's no medication, no supplement, nothing to treat social communication difficulty and restrictive repetitive behavior. So there are some research showed that some medication might be helpful, but so overall, there's no medication proven to be helpful for these symptoms. So only behavioral therapy and other kind of therapies can be helpful for communication and behavior. So why do we use the medication? So the medications are very helpful when a child is agitated or anxious, they are angry, but or they are hyperactive. So they need to work with teacher or the therapist, but they cannot sit still. At the time, the medication can help them to focus or pay attention or listen to their therapist or help with their anxiety so they can be in crowded area. So the medication enables to do other kind of therapy. And standard care for the therapy is the first line ABA, speech therapy and OT. But autism is very different. It looks different in every individual, and also it looks different at different ages. Like a toddler with autism or a student in elementary school or high school, or maybe in their 20s or 30s, they look different from each other, and also they have different needs. So they need a constant observation and constant evaluation to understand their need because they are growing up and then their need constantly changing. It's important to connect with a doctor, a provider, if there's someone, a child psychiatrist or autism specialist, to visit their doctor regularly. It can be like every 3 months, sometimes every 6 months, even just once a year. It's a good idea to connect with someone and then work together. So these are the reasons we use the medications in autism. So these are the most common symptoms we see: irritability or aggression, and hyperactivity, not paying attention. This can be like a challenge in school and can get in the way of learning the therapy. And depression, anxiety, as mentioned before, is very like common in autism. So they can also affect their communication, like social interaction. They may struggle to leave their home. They prefer to stay home because they feel anxious being outside in crowded places, or they may be anxious in a different new area. And we also use medication for sleeping difficulties. So this is how actually explains very well we treat the neighbors that live alongside autism. So autism doesn't have a medication treatment that cures the core symptoms. So this part is usually medication management is my specialty, my area. I focus on the medication part. And when we are treating anxiety, depression, like hyperactivity or sleeping difficulty, sometimes the common medication we use in general are not effective in autism, or sometimes they cause a lot more side effects in autism compared to other people. So we don't have a lot of study in this area, but we know some medications are more helpful than others. And then usually they need a different approach than general population. I think irritability and aggression is one of the most common symptoms I see in my patients. And because the communication is one of the core symptom and then deficit, they usually cannot express themselves very well. If they're not talking, it's hard to understand what makes them irritable or angry. And then sometimes it can be part of autism. They can be irritable constantly all the time. We have two medications. These are approved by FDA, and then these are very effective medications, but it's very tricky in psychiatric field. Sometimes what you see can be like different in every patient. For instance, someone is irritable, maybe it's part of the autism, but another person is irritable because they are anxious. Maybe another person is irritable because they are constipated or they have a tooth pain or maybe they have a medical issue going on. So this is very important to understand like what's going on, if there's any change, its irritability, but what's happening before it starts, during the episode, or after the irritability. So this is why we need help from families because they know them very well and then they are with the patient all the time and they observe. So based on the underlying reason, the treatment can be also different. So motor hyperactivity and inattention. So this is core symptoms for ADHD. Studies show that if someone has autism, there's a high chance they also have ADHD. I think the comorbidity is around 80%, which means like if someone has autism, like 70-80% chance they will also have ADHD. And sometimes ADHD get in the way of getting a treatment and improvement. So they start ABA therapy, they start early intervention, but when we talk with the therapist, they say it doesn't work because they cannot pay attention, because they cannot sit still. So now the medication is very helpful in these cases. As I mentioned earlier, like the medication for autism, the approach is very different. For instance, a neurotypical child, when they have ADHD symptoms, we use stimulant medication because they are the best. But when it comes to autistic children, stimulant medication usually makes them more angry and makes them more irritable, especially during the early childhood, like preschool ages or elementary school. So we start with non-stimulant medication first. That helps a lot because they also have other benefits. As they grow up, we slowly switch to stimulant medication, like in middle school or high school. Depression and anxiety is also common. So SSRIs, probably you heard about them. So sertraline, Zoloft, or Lexapro, the most common medication, and Prozac, maybe the most common psychiatric medication used around the world. But when it comes to autism, these medications make autistic people more anxious and more irritable and agitated. So I try to avoid SSRI medications when I start the treatment first, but there are some other medication. So in the Lurie Center, they did research. The study showed that buspirone is milder than SSRIs, also more effective. So it's tolerated better and it shows benefits significantly. Mirtazapine is another medication I commonly use for my patients. It helps with sleeping difficulty, depression, and is tolerated very well. So there are many other medication I didn't put here. Like every individual is unique and every situation is unique. So based on the underlying reason and presenting symptoms, we may use variety of different psychiatric medications. I think sleep disorders is one of the most common comorbidity in autism. I remember I was seeing like preschool age children, 2, 3 years old. They have like sleeping difficulty, they cannot sleep. And so when they are not sleeping, they are more agitated, irritable, and it can be very challenging for family. because like in the end, everybody needs to go work. They need to like take care of themselves. It can be challenging for families to take care of someone who is showing sleeping difficulty and other symptoms. So it doesn't mean that when we see a behavior, we need to give medication immediately. We need to understand if this behavior affecting the treatment, affecting the success, academic achievement at school, or impairing the function at work, or is it a dangerous behavior putting the patient in danger or other people in danger, and then decide whether they really need a medication or not? Because all medications, more or less, they may cause side effect. So our priority is to treat the behavior with behavioral intervention first. But if it doesn't work, and medication can be very helpful. So this can be summary, the expectation from the medications. Medication can help with irritability, anger, tantrums, can improve focus and attention, can help with anxiety and depression and improve sleeps. But the medication doesn't cure autism. It doesn't teach any social skill, and it doesn't help with speech. So this requires like behavioral intervention and speech therapy. There are some medication, those are experimental. Recently at Mass General Brigham, they published a new article. Dr. Joshi, I worked together. So there's a medication called memantine, and then the study, they showed that memantine makes autistic individual a little bit more social than before when they use that medication. Memantine originally used for dementia forgetfulness in older people, but seems like that can be something we will learn more about that in the future. So one of the interesting thing about medication in autism, so they are very, very sensitive to side effects. And then we start like tiny, like baby dose when we start a new medication. Even sometimes they cannot tolerate the medication, and somehow their body is different, and then they give out of reaction and then show side effects. So that is a good idea to start the lowest and then be patient, go slowly. And we only change one medication at a time, give time to body so they can adopt the medication. And most importantly, we need to work all together, therapist, family, and doctors. And it's a teamwork. And then we need all each other to like help the patient. So these are the studies mentioned, did they like research and other uh, medication research, so showed us what is helpful or what's not helpful. I don't know if I did very fast or slow, but I think we have more time to talk about the questions.
You did perfect. It's great. Thank you. I know I was taking a lot of notes and snaps, so I don't know if anybody has any questions. We can open it up. You can write it in the chat or you can unmute, raise your hand. We'd be happy to take questions.
I have a question, if I
All
may.
right. You bet, Rob.
When you're talking about changing variables, would you wean off of one medication before replacing it with a new medication? Is that what you were talking about, doctor? Something along that line?
Are you asking if whether I try a medication until the maximum dose before I give up, or
No, I was more into, say I'm taking medication A and I'm finding that we may have been on that a while and we want to switch to medication B. Would we completely wean off of A before adding B, or do it in concert at different levels, if that makes any sense?
yeah, I think I've been to many times in this situation and it can be tricky. I guess it depends on the symptoms, the medication. So sometimes I start the new medicine and then wait until I see benefits. And then if I see benefits, and then I gradually lower the old medication and stop. So, and again, it depends the symptoms and medication. Every medication has a different strategy. And sometimes I prefer to taper off the first medication and then see how someone is doing without the medicine to understand the baseline. And then, so it's because it can be tricky, the medication can cause some symptoms, side effects, and then, or the patient might have the symptoms at baseline. If someone is new to me, if I don't know them, I don't know if it's the medication induced or if it's the original symptoms. So then I stop the medication slowly and then give a couple of times, a couple of weeks, and then start from the scratch.
Thank you.
That was good. All right. So let's see here. I have a question from Rachel. She wants to know, can you talk about, and I don't know how to pronunciate this,
Calvary?
Quelbury, yes.
Yeah. So when I mention ADHD treatment, so there are two groups, stimulant and non-stimulant medications. And then Qelbree is one of the non-stimulant medication along with atomoxetine. Atomoxetine, Qelbree, like they're in the same like category. So Qelbree is also atomoxetine. It's helpful for ADHD, hyperactivity, inattention. It's relatively newer than other atomoxetine. And then studies show that it starts working faster than atomoxetine. But overall, this medication takes like 2 to 3 weeks time to show some benefits. And so it's a good, helpful medicine. There are some medication I can tell this medication is not tolerated well in autism spectrum disorder, like some SSRI, but I didn't see anything about Qelbree. So it can be used in autism.
Excellent. Thank you. Our next question comes from Denise. What are your thoughts on levocorvin?
Look over it.
Levocorvin?
Yeah, there was a great presentation at Lurie Center a month ago. This is a common question everybody is asking. We are also, as a doctor, learning a lot about leucovorin. So Dr. Carey and Neumeier, they are so great. So doctors working there for years. What I learned from them, so we are cautious at this time because we didn't use this medication in the past. There are a few studies they showed they might be helpful for speech delay, but it doesn't mean that they're helpful for autism in general. And when I talked to some colleagues who tried this medication, they reported that some children, so they become very irritable when they use this medication. And so they didn't see significant benefit on the other side. But this medication, what I learned from my colleagues and Dr. Neumeyer, so some certain rare patients, they have a problem with folate vitamin. So the brain cannot process that folate vitamin. In that case, it's very, very helpful because leucovorin is also a sort of like folate vitamin. And so if that's the case, it's very helpful. But in other situations, so now we are trying a little bit, but still very cautious about that.
Excellent.
Can I ask a follow-up question?
Sure.
So how would we go about finding out, like, if our child specifically may be struggling with a folate deficiency? Like, what path do we need to take to figure that out?
Good question.
Yeah, that's a good question. We are still trying to create like a guideline about that. So you can recommend a testing for folate metabolism from pediatric doctors. I'm not sure if the insurance company is covering or not. And usually, if someone has those kind of genetic abnormality, they usually have higher level of autism. They also have other symptoms like developmental delay. And we also recommend a general genetic testing to rule out a variety of genetic disorders. And then, so that can be also added to the testing.
That's great. Thank you.
I
Denise
see
wants...
melatonin question.
Yep.
Melatonin is a hormone. So far, the studies didn't show much side effects. It's over the counter. If it's helpful using for 2 years or more than 2 years, I recommend to continue if it's helpful. So it can be used for a long time without problem.
Excellent.
And the clinical trials, I don't know if you are asking for a specific topic like treatment or diagnosis. There are really nice trials. And recently, MGH published a medication. And so that can be something like the most recently very helpful. And I see Camille tried clonidine, guanfacine, Ritalin, and risperidone. Yeah, medication, as I said, so autistic children, they usually show a lot of side effects. And if a medication is not working, it might be the good idea to look into the behavior, maybe repeat the evaluation to understand if we have the right diagnosis. So if we are treating the right symptom, and if our diagnosis is the right, our symptoms, we understand it very well, we understand the underlying reason, and then so we can try some other medication. But I see you tried the most commonly used medication in autism. In order to tell more, I think I need to maybe know more and then give you more specific answer. But I think the best recommendation is if these medications are not working, it might be a good idea to repeat the evaluation. So, Concerta masking ADHD symptoms. So, Concerta helps with ADHD symptoms in autism. So, it doesn't mask because it cannot fix the core symptoms of autism. So, when you give Concerta, it's a stimulant medication. It helps with ADHD symptoms. If you remember in this slide, it says the neighbors. It helps with the neighbors, but not the core autism symptoms. So no medication can mask or improve the difficulty with communication, social interaction, and understanding the cues. So some symptoms may improve, but the other core will be there.
Excellent.
I think the pharmacogenomic testing is very popular topic. Sometimes my patient also ask me about that. So there's a common misconception about pharmacogenomic testing. People think after this test, we will know what medication works best for our children. Like our body, when we take a medication, it goes to our stomach, our intestine, and then into our blood. And then liver takes the medication from blood and then process the medication. So during this process, so the medication is eliminated from our body. And sometimes our liver, the enzymes in our liver works very fast. So before the medication reach to brain, the liver cleans our body from the medication. So these are called fast metabolizer. Sometimes it can be ultra fast. For instance, a medication should work like 10 hours, but the liver works very fast and then cleans the body from the medication. So the medication is cleaned like in 2 hours. So how do we understand that? Like you give Concerta 18 milligram, it doesn't work. 36, it doesn't work. 54 milligram, it doesn't work. You give 100 milligram, it doesn't work. And you don't see any side effects. It's like it's not touching. And then you think the medication doesn't show any benefit, doesn't show any side effect. I wonder if the medication really reached the brain, or maybe the body metabolizing is very fast. And then we do this testing to understand if someone processed the medication slowly or fast. And then if they are fast metabolizer, we give very high dose before the body process and get rid of the medication. The medication reaches the brain and then shows its effect. Or sometimes you give very tiny dose, you see a lot of side effects. So they can be slow metabolizer. And then we do the testing to understand it. If they're slow metabolizer, we give very, very tiny dose because they are slowly processing the medication. So it only shows us the speed. And then if they are very fast, we give more dose. Very slow, we give less dose. But it doesn't tell us whether a medication is going to work or not. Yeah, that's a good question. Is that ability to metabolize genetic? I mean, it's genetic. Some genes affect our enzymes. And so some genes make our enzymes work faster or work slower. But if you're asking if it runs in the family or not, I'm not 100% sure. So sometimes it doesn't run in the family, but it's still controlled by our genes. Then we call it genetic, but it may not be inherited.
All right. Excellent. Very good. Any more questions?
Can I have a quick question, please?
Sure.
I've been, with a lot of medication for my son. He's not in school anymore, but when he was in school, and I understand, it's say like we have to work as a team. The doctor, the therapist, the teacher, the parents, we all need to work as a team. I always have a question is every time we need to change the medication, should we notify the teacher first, or we should wait for the trying period like 2 weeks? So, like we want to get the honest, fresh idea, you know what I mean? But is that so risky? Or we should give them the notice in advance, or we should wait after the few weeks? That's my question.
In my opinion, so the question can come from any team member, like the question can come from teacher or family. And so you can talk to the doctor first, but in the end, so we need the information from teacher. And I think the best idea, usually they have some problem at school and teacher tell you, or there's a problem at home. You should ask the teacher if they also have the same problem at school. And then communicating with the teacher is the best idea. And then both together, you can go to your doctor and then you can tell them, hey, we see this symptom at home and also at school, so we need help. Or you can say, I see this symptom at home, but not at school, we need help. So these are what your doctor needs to understand what's going on.
Excellent. Very good. All right. Well, thank you all so much. This was just incredible. Huseyin, thank you very much for being here tonight and providing us with great information. And we will have this recording and we will share it with everybody. So you're getting tons of thank yous through there. So this is excellent. Thanks a million, everybody. Thanks for being on here. Have a
Thank
good
you for
one.
coming here. Have a good night.
Thank you so much. Have a good evening.